What about strategies for preventive treatment?
We had criteria and a number of criteria. First and foremost, if a person continues to have severe headache despite acute treatment. 2, if they have 1 or more migraine headaches a week, they should be treated because of the risk of getting daily headache. 3, patient preference. If a person is in an occupation where to have a migraine would be horrible, like if you play football, if you're a neurosurgeon or an orthopedic surgeon, can you imagine having an orthopedic or surgeon or neurosurgeon operating your brain and going blind from his migraine?
Speaking as an anesthesiologist, who could tell the difference? But that's another question for another day.
That's a different issue. And then the other issue would be medication misuse, overuse, and last, unusual disorders like hemiplegic migraine, migraine with prolonged aura, basilar migraine. Those would be the indications for treatment.
I mean, I don't want to make light of this, but this is a nasty disease. If a certain percent, well, let me put it this way. What percent of all patients probably should be on preventive treatment?
Of all the patients with migraine,
All comers.
40% should be on it and only 13% get it.
I was going to go to that other half, and you beat me to the punch. All right. From a payer's perspective or employer's perspective, huge gap here. People who should be on it, people who aren't on it. Why not? Are there criteria that you're using different than the criteria that he's using?
Well, I think the major reason is educational. And what employers are doing is educating employees and their families about the seriousness of migraine, the impact on work, and so forth. In terms of benefit plan design, the pharmacy benefit managers that major employers use have a design, and there's a pre-approval process depending on which migraine drug is used.
I'm going to ask it again, because I heard word salad. Pre-approval, there are procedures. Let's boil this right down, shall we?
It's the cause of the opioid epidemic.
It's
if
a
you're
cause.
a family doctor, you have it, and you in the older days, you want to spend an hour on the phone getting a triptan for your patient, or you can just write a prescription for a narcotic.
But again, there's a huge gap, all right? And I'm playing devil's advocate. I don't mean to be flippant about this, but a lot of doctors complain about this. They know what they want to do. They know that they should prescribe. They know that preventive treatment is right. And the paperwork, or in this case, in this day and age, the silicon work, beats the ever-loving something out of them, and they give up. Why is that barrier there? I'm assuming there is a barrier.
Well, let's put into perspective
Please.
that we do have generics, right? So generics usually do not have barriers, and those include the triptans. And unfortunately, many times what a payer sees is utilization. So we will have things like quantity limits that are based on a per prescription fill, which can be seen as a barrier, but it's also the reality of the costs associated with some of these therapies. So in general, generics, especially now that we have triptans, are not a barrier to access.
Okay, if I hear what you're saying, there are no barriers. There are very few barriers. Cost, because there are generics, and some of these drugs are not the reason. So why is it that he wants more people on preventive treatment and they're not getting it? Is it you?
Well, also, let's look at what else, what are the options that can be used for preventative therapy that hopefully, from a patient perspective, especially given generic options, offer the ability for patients to afford these therapies long term. And so back to the generics that are also encouraged as first line for the guidelines, and those include the beta blockers, those include really optimization through a process which includes the beta blockers, antidepressants, et cetera. So we usually think of those lower cost options first that are also based on guidelines and evidence-based medicine, including topiramate as well. If there's contraindications to these, that's usually when the prior authorization kicks in to try to move upstream potentially higher cost agents.
But you understand the frustration, right? Which is, I've got a patient with migraines. There are really good drugs out there. I'm calling you and you're going to say, give him a beta blocker. And I'm going to go, no, I want to give him something that works.
Then tell us why.
I disagree with you. There is no scientific evidence that any preventative drug works more than half the time. And I do not think And today, most people who failed have tried beta blockers or topiramate or divalproex or or SNRI or amitriptyline. I think the way to look at it is, if there's a medical contraindication to taking a class, let's say you have bradycardia, you can't take a beta blocker. Let's say you're manic, you can't take an antidepressant. So if there's no, so basically my bias, and I think many of the companies are reasonable, that if you failed or have contraindication to the major drugs, you're eligible to move up, whether it's for botulinum toxin or to an antibody. I think the problem is not the rules, but once you've made the criteria, the difficulty of going to the next step. And my advice to the payers would be, if you meet the guidelines and you say you have to fail 2 drugs, why not automatically approve it instead of having to talk to 10 people? It costs you money, it costs us money, and I think the process could be simplified.
I think the other point here too is that more and more employer-sponsored plans are in high deductible plans. So the employee has high deductible, it's out-of-pocket expense, and they really will want the lower cost options tried first before the higher priced options.
So it may be worse than I even thought. If what you're telling me is this large percentage of people are undertreated or not treated adequately, it's not that they're getting the newer expensive drugs, they're not getting even the cheap stuff.
That is correct.
So whose fault is that?
That's a really good question.
Thank you.
Part of the problem is access to healthcare practitioners who actually are educated in diagnosing and effectively treating migraine. That's a huge problem in America, actually globally. So we only have just over 500 certified headache specialists, I believe, right now. But we have nearly 40 million people with
47.
migraine. Right, okay, so much worse than I thought.
He's picky about this.
That's
No, the
good.
new number just came out.
Okay,
Right.
that's wonderful. So, and is the number still about 6 million who are chronic?
Correct. Yes.
So it's a little bit higher. So if you were to put that down with the number of patients who have to be seen by every certified headache specialist, just those who are chronic, it's completely undoable. So first of all, just find a physician who knows how to treat is a huge issue. And then you have the problem that a lot of insurance plans do not cover certified headache specialists. There is none in their network. And then you will go to one neurologist and then another neurologist, most of whom are actually specializing in other areas like movement disorders.
Oh, that's just great. Before we move on and change the topic just slightly, let's put a button on this. What is the AHS position statement for the migraine preventive treatments? What is the statement?
Basically, the American Headache Society, and I helped write the paper, adopted the guidelines that we created for migraine treatment, the same basic concept. And they basically say that people should have the right to use the new monoclonal antibodies at the appropriate stage of their treatment and not have to go through hoops to get it.
All right.
Yes, I'd like to add there that there is a sense among the migraine community that the decision for effective treatment has been taken somewhat out of the hands of the physician and the patients and put into the hands of the payer, who doesn't actually know all the patient history and the implications of the treatment. So your doctor will prescribe one medication, the insurance company will say, no, you have to do this, and it's very complex.
Is that fair? I'm going to give you one last pop at this. They just took a swipe at you. You want to swipe back?
We love guidelines. Guidelines really help us try to not only be evidence-based, but also cost-conscious. So if a guideline appropriately defines who is the right patient, what should the sequencing of options be, I think we all need to keep in mind that you can appeal, and there's always circumstances in which you may not quite fit the step approach. But we usually start with guidelines in terms of crafting policy.
It's the right drug and the right patient at the right time.
Yes.